Welcome to euroPCR 2023 and to this discussion on advancements in the management of bifurcation lesions. My name is Dr. Ashok Seth from New Delhi, India, and I have with me today Dr. Rani Mathew from Kochi in India and Dr. Rishi Sethi from Lucknow in India. We're going to have a wonderful discussion around a very complex group of patients, the bifurcation lesions, which are increasing in our practice and always cause of concern for us. They are complex lesions. And over the past few years, we've learned through bench testing, through simulation models, better management strategies to treat such patients with safety and efficacy. So I think we're going to discuss a bit around that and to understand around how we have actually moved the science further for these very difficult and complex lesion subsets. So, Rani, tell me about the bifurcation lesions you treat in your practice. Do you see a lot of them? Do they concern you at all when you find a bifurcation lesion? Say it's got a large side branch, and how do you assess these bifurcation lesions and decide to treat them?
See, bifurcations probably come to about 20% of the entire interventional procedures we do. And I think the important thing of bifurcations is that there is a technical challenge involved because it's a complex lesion and the procedural outcomes are not too good. Long-term outcomes are bad. And no two bifurcations are the same. So there are no standardized techniques for these bifurcations. So in my practice, the predominant bifurcation that I consider important are the ones that have a true bifurcation, that is a side branch, that is clinically relevant. And what I mean by clinical relevance is by any side branch that subtends more than 10% of the myocardium. So we got many surrogate markers for that.
Right.
So I think...
Any size of the side branch that you think is important in terms of millimeters?
Yes. So when I say a side branch is clinically relevant, it should subtend 10% of the myocardium, which translates into roughly a size that's greater than 2 millimeters.
Right.
Or a length generally considered by everybody as greater than 73 millimeters. And in my practice, I think it's generally the LADD one and the circumflex left main that are the most important parts of bifurcation.
So let me just understand this. That circumflex left main, the most important bifurcation, should we say, and truly a lot of concern as well as discussion around that happens as to the best way to approach the distal left main circumflex bifurcation. So what in your practice is this percentage of complex left main circumflex bifurcation?
So complex left main bifurcation, which we'll be thinking in terms of being careful about protection of side branch. In cases of overall left mains that we do, it would be nearly around more than 50% in the bifurcation that the left main situation is concerned. But in the overall clinical picture and overall percentage of patients, they would be somewhere around 10% of our population where we would be considering that.
So Dr. Rishi, let me just ask you, do you have a strategy which is different for native vessel non-left main bifurcation versus left main bifurcation as far as stent strategy is concerned, as far as choice of techniques are concerned? Can you just elaborate on how you decide on this?
So taking forward for what Dr. Rani was saying, that we need to have a side branch which is supplying a significant territory, which is almost always the case in left main, unlike the other bifurcations.
Absolutely.
Having said that, LAD-D1 bifurcation is also a close second to left main bifurcation, where the diagonal is more than, let's say, greater than 2 millimeters, let's say a 2.5 millimeter that we would consider. In the left main bifurcation lesion, apart from the size of the side branch, which of course always be significant, we also have to take into consideration, and we take into consideration, what is the probability of that side branch getting occluded, seriously compromised during the procedure, and therefore the angulation of that circumflex from the left main, the amount of disease at the ostium of the circumflex and how long is that disease in the circumflex, and also the amount of plaque burden in the native left main. All these things would be consideration that we would be taking into our thought process in deciding the strategy for left main.
So Dr. Rani, let me get from you your choice of strategy. Say we're not now talking about non-left main bifurcation. What is your choice of strategy for a non-left main bifurcation? Say an LAD, diagonal, large diagonal bifurcation. How would you approach that? And even for left main, say, it's a Medina 111.
Yeah. In my practice, I think the default strategy for me is always a provisional stenting. When I mean a provisional stenting, I mean for true bifurcations, you stent only the main vessel,
right,
and you try and open the side branch only with a balloon if necessary, without putting a second stent in. And I think the decision is taken based on a lot of parameters: the plaque burden, the differential size of the vessels, the bifurcation angle. And I think it's based on that you would decide whether to do a two-stent strategy up front or a provisional. But to your question, my default strategy is generally the provisional.
So you would actually, therefore, protect the side branch, prevent it from closure, but you would not necessarily stent it, and you would only have a layered approach. Well, from what I understand, that if the side branch was closing, it had a dissection, or whatever needed to be bailed out, then you would go ahead and send the side branch in a provisional strategy.
Absolutely.
Right? Okay. So that's a nice way to proceed. So then, Dr. Rishi, then it brings me to the point that we have, and most of us do follow a provisional layered strategy for bifurcations.
Correct.
But what is your strategy? When do you use upfront two-stent strategy? You decide, you look at the vessel and say, I'm going to have to put two stents in. Let me start with a two-stent strategy rather than a provisional layered strategy.
For the upfront two-stent strategy, I would generally, in my own mind, classify the bifurcation as a high-risk bifurcation or the low-risk bifurcation. It's a given a fact that left main bifurcation that we are talking about, the size and the importance of the side branch, is unquestionable. So what is the probability of it getting closed is something that we would decide. As already discussed, it would be based upon the angulation and the plaque burden and so on and so forth. However, another one thing that is also important in my mind is what is the clinical indication that we are looking at.
Right.
If we are looking at an acute coronary syndrome where the speed of the procedure is important and we have to deal with the culprit vessel and get the flow growing, I would rather just keep it simple, even if the side branch is important. But if the condition is of a stable coronary artery disease, there's no point treating the main vessel and continuing to have angina from the side branch. So in that case, I would lean towards a two-stent strategy up front.
And that's true. I think the choice of stents, and it's not just the technique, the choice of stents is also a very important factor in deciding around many of these strategies, whether it's provisional or two-stent. And of course, the amount of disease burden in the side branch, the extent, the length of the disease, are all very important indicators. So Rani, do you have a choice of stents in these sort of situations? We have the strategies, but always we have some preferences toward the choice of stents. What are the factors that you consider in deciding what stent would you like to use for a bifurcation, should we say?
Generally, for me, a bifurcation lesion always requires imaging. So I generally image about 80% of all my bifurcations, whether it's OCT or IVIS. So once you get to know what is the morphology of the plaque and what are the actual sizes, the differential sizes, it's important to understand that you must take a stent that can differentially size. So suppose you take an LAD to left main, the LAD should be 3.25 millimeters, the LM should go up to 5.5. So one of the very important aspects that I take is the expansibility of the stent.
Right.
And I think another very important point is the access to the side branch, because I think there lies the crux of the bifurcation stenting. So I would generally prefer a stent that has got a good side branch access and that has a good expansion and gives you sufficient radial strength, especially when it is a left mains.
Oh, that's so right. It then brings us to the point that know your stents well and know their expansion characteristics as well as the side branch lumen that your stent can create, just in case you had to not just cross it, but even stent the side branch. So Dr. Rishi, that brings me to the point. Do you have a favorite among stents for bifurcation lesions, and why?
So I think most of the newer generation stents have almost nearly the same kind of characteristics. So I would say that in terms of as a blanket practice, I would not say that I would choose one stent over the other. Having said that, if we dissect it to find, and if we try to look at the lens, the stents under a magnifying lens, then we would realize that the thinness of the struts I would be considering as an important factor, because even for provisional, if you say, I mean, 2 stent definitely, but even for provisional, we say provisional does not translate into a single stent strategy. It only means that, single stent strategy is an upfront strategy, and we should be prepared to convert into a 2 stent strategy. Absolutely. So we have to have the same consideration for provisional as well as the 2 stent strategy. So in that case, I mean, I'd like to keep the metal at the carina as least as possible. So a thinner struts would be beneficial. Of course, the amount of expansion a stent can achieve over and above its nominal size, which is especially important in the LED left main kind of situation, there would be a size mismatch, and we want an approximation and of the left main with the expansion, the stent to be achieved too. And then also, what is the kind of geometry the stent has been designed to have, the stent design has, implying what is the area of a cell in a normally expanded stent, and how much can we expand that normally the cell area so as to ease the delivery of devices in the side branch. So all these factors would be
the size of the cells, in fact, the expansion of the size of the cells that you create, which also are important, which brings me to the very important aspect, ultra-thin stents, the new generation of ultra-thin stents. And we're lucky that we ourselves have in India, in our use, one of the well-used and well-proven ultra-thin stents, the Supraflex screws. So, Rani, do you use Supraflex screws in your practice because it's an ultra-thin stent? Does it have any advantages in your practice in bifurcation lesions?
Yeah, I do use Supraflex screws, and I think there are some distinct advantages to this stent. One is it's got a very unique Z connector. So, you can get flexibility. And because of this Z connector, and as Dr. Rishi was saying, you get a cell size, an area that's generally larger than other stents. So you have a greater access to your side branch. Your chance of a connector falling exactly bang on the ostium or the circumflex is less likely when you've got a larger cell size. Recrossing is much easy. So I think overall, Supraflex screws would be a good stent for bifurcation. Ultra thin, large cell size. I think it ticks 2 boxes.
Right, and the ability to expand to large sizes. So the taper is maintained. The physiological taper of the vessel can be maintained. So it seems a good stent for left vein bifurcations as well. One of the other, I think, plus points in all this is that what you mentioned, Dr. Rishi, metal, thin metal. But, as we always fear that bifurcations, when we, especially in 2 stent strategies, going to have a lot of metal at the carina, and therefore it's intuitively correct to have thin struts so that you don't have thick metal sitting out there. So in your practice, do you use it in all forms? So here's a thin strut stent, and I'd say you've got a heavily calcified bifurcation. What's your experience for a thin strut stent in a heavily calcified bifurcation?
So before I answer that, I would like to continue on one important point that is important with this particular brand of stent, the Supraflex screws, is that whereas many of the competing brands would be discussing about their ultra-thin structure, this particular stent, especially when we are using in large diameter stents in left main bifurcation, maintains that ultra-thin structure across all stent sizes, which is not so much so as the other brands. So that's one important thing considering left main bifurcation. As far as calcified lesions are concerned, I see no reservation not to use thin strut stents, because most of the ultra-thin or thin strut stents have the radial strength, which is very nice. The deliverability of the ultra-thin is actually better. So I think I have no reservation in calcified bifurcation lesions using ultra-thin stents. Of course, provided that we have prepared the bed well with whatever adjuvant therapy.
And the basis is that you have to prepare the lesion well.
Yes.
And therefore, the thinness of the struts can only be an advantage and never a disadvantage.
Absolutely correct.
I think those have been really pearls of wisdom from 2 very experienced interventional cardiologists from India, Dr. Rani Matthews and Dr. Rishi Sethi. Thank you very much for this discussion. We know that advancements in technology have played a major role in our dealing with these complex bifurcation lesions, and we're glad that the thin strut, Supraflex screws, as we say, has proven a very advantageous tools in our hands, especially in our day-to-day practice in these very complex lesion subsets whether it is a provisional strategy or whether it's a two-stent strategy. And I think these have been one of the advancements of science to benefit our patients. Thank you very much for this discussion.
Thank you.
Being here at the euroPCR 2023.
Thank you.
Thank you, sir.